This conference will now be recorded.
Hi, good afternoon. My name is Shira Steinberger from Weill Cornell, and I'm excited to present the May Curious Cases Conference. Let's get started. This is meant to be interactive and very casual, so feel free to stop me if you have any questions or comments. I would love to hear from you. So I actually wasn't sure what topic I wanted to do or if I just wanted to do a bunch of different cases. And then a couple days ago, I had this case from the ER, which I thought was sort of interesting, especially if there's any trainees listening. So this is a 32-year-old woman. She presented to the ER. She had no past medical history. She had palpitations and shortness of breath. This is just copied from our EMR. She was tachycardic to the 200s. And basically what happened was they did a bedside echo. They saw an enlarged right ventricle, maybe some septal bowing, and they decided she must have a pulmonary embolism. They should anticoagulate her and get a PE study. So that is what they did. So this is our study. I'll let it play through once or twice. And then I'll give you some stills in a minute, but just so you can take a look. Okay, so there was a junior resident covering the ER. They read the case actually appropriately. There was a lot of stuff in the patient's lungs. I'm not really showing it to you here, but they said maybe there's some atelectasis, maybe there's some pneumonia. And then they said, this patient has a very large right ventricle, big right atrium, big pulmonary artery. They made all these findings, but they didn't figure out why the patient had these findings, right? So they said there's no pulmonary embolism. This is a young, otherwise healthy patient. So whenever you see something like this, you should take a minute and think that maybe we're missing something, right? So when we go here, we can see these the top two images on the left. So this is just showing you the very large pulmonary artery. And then if you look here, you can actually see it's really hard on a PE study with all the mixing, but you can see there's a big hole here, right? Between your left atrium and your right atrium. So this is a big ASD. This is a secundum type ASD, atrial septal defect. And then the patient actually went on to get a cardiac CT, not for this. She also has an aberrant circumflex coronary artery, which is why she got the cardiac CT. But anyway, so you can see it better on the cardiac CT here, but certainly there's a big hole here. Now, if you're reading this cardiac CT, you're not going to miss the big ASD, obviously, but I do think it's easy to miss them when you're reading a motion ER scan where there's a lot of contrast mixing. So just remember, if you see a big heart, especially big right-sided heart, right, always think about shunts. Could I be missing a shunt? And just take another look. She ended up getting a cardiac MR. I spared you most of the images because it wasn't a great study, but you can see here just how large her right ventricle is. We did a QPQS on her and it was really impressive. It was greater than 3. So certainly intervention is needed. So I wanted to talk a little bit about holes in the heart and then just some other anomalous vasculature. So we'll go through a bunch of cases. So this case that we had, here's another example, right, of the same thing, right? So here we can see this is our right atrium, our left atrium. There's a hole in the middle, and you can see the contrast is pouring through. This is a secundum ASD. So it results from inadequate formation of the septum secundum, so it doesn't totally cover the ostium secundum. And this is going to be most of your ASDs, right? So if you're looking at an ASD, especially for a boards question, and you don't know what type it is, just say secundum, and you're probably going to be right most of the time. And, the way that we tell the difference between this, I'll show you some cases of PFOs. This is going to be larger. And usually if the QPQS is greater than 1.5, that's when people will start to close these. It can lead to, if it doesn't close, right, what's the problem? So we don't want there to be right heart dilatation, as we saw in our patient, and pulmonary hypertension, which she had, and then that can lead to Eisenmenger's physiology, which is obviously not a great thing for our patient. Here's another case on CT. You can see here's the ASD, a secundum type right in that location that we're familiar with. It looks just like our other patient. Here's another one. I think now you get the point of what a secundum ASD looks like. Okay, so these are some illustrations which I did not make. These were made by Adam Jacoby, and I think they're really helpful. It's like very, very basic embryology. I'm not going to get into anything too detailed or crazy. Just so that you can sort of see like what we're talking about, the anatomy. So we start out essentially with a common atrium. And what we have here on the right, here's the right side of the heart, here's the left side of the heart, and then we have our endocardial cushion and our valves down here. And what happens is, so first we have our septum primum, and inferior to the septum primum, this area over here, when blood is flowing through here, when there's a hole over region between the septum primum and the endocardial cushion, we call this is our ostium primum, so our primum AST. And so that's what we see here. So this is much lower down than the secundum ASD that we saw in the prior image. So this is going to be our second type of ASD, our primum ASD. So ostium primum ASD, so that septum, the septum primum and the endocardial cushion have not fused together. So this is going to be more inferiorly located. This is more rare, usually about 2 to 3% of ASDs. And then this is the one when we talk about endocardial cushion defects, and especially in patients with Down syndrome, this is the type of ASD that's associated with that. This is just an echo image to sort of show you that you now have a full endocardial cushion defect. Okay, so that was our primum. So now we're going to move on to our secundum. So now we no longer have this hole right over here where the ostium primum is. But now what happens is we have our septum secundum, we have our septum primum, and now there's a hole between the two, and it's more superiorly located. It's not quite so inferior. So this was the case that we have. This is our secundum septum. So now we understand sort of what it looks like. So let's move on to our second case. I'll let it play through for a second. Okay. I think there's an echo. I don't know. Okay. Maybe it got fixed. All right. Okay, so here you can see, again, left atrium, right atrium, and now we have a jet of contrast, right, that's shooting through. So this is a PFO, right? It's much smaller looking. They don't always look exactly like this, but I think this one's a nice one. Here's just a tiny little PFO that shoots through. Sometimes they can be even less conspicuous in comparison to this one. So what is a PFO, right? So here's our foramen ovale, and we just have this tiny bit of contrast that's sort of like going right through our little tunnel here. That's our little patent foramen ovale. So the foramen ovale remains patent, and the contrast now goes through from the left to the right side. And we see these pretty frequently, right? So this is the prevalence is about 25%. And because of the bidirectional shunting, there's also a risk for paradoxical embolism. So this is important, especially in cases in patients who've had a stroke. So definitely important to mention this. And we do see it quite often. Here's another one. You can just kind of, you don't really see the hole, but you can actually see the jet, which is kind of nice right there. You can put on a moderator band. Sometimes that might help you be able to visualize the jet even better. Okay, so here's a companion case. I'm actually curious to hear what people think about this. I don't really know what to do with this. So this is interesting. Sorry. So does anyone want to take a case? I don't know who's on. I can see. No.
So there is like a membrane, like or outpouching through the atrial septum. That sometimes it can mimic like a PFO or atrial septal pouch or or hypermobile interatrial septum. Sometimes I get confused between the three on the CT when I see that appearance.
Thank you, Shaima. Good. So this is a septal pouch, right? So, you know, I didn't used to mention these. Now I will sometimes mention them when they're prominent. We have radiologists and cardiologists in our group who mention them all the time and who feel strongly that, you know, there is this questionable association with some stroke, with increased risk of stroke. It's in, I think, about 40% of the population. I don't know if I have, here. I think it's in about 40% of the population. I see them all the time. I can't imagine it's all that significant. I am curious to hear what other people are doing, if you're even mentioning them or just leaving them alone.
I used to mention them because some patients, they referred by echo and they are questioning about PFO, and they go back to the CT. Do you see something to tell you that there is a PFO? So I tell them these are the three differential possibilities that I have for such appearance. But I also didn't used to mention them, but nowadays this year I'm mentioning them in every single patient.
Yeah, I also started mentioning them, but I don't know how I feel about it, honestly. But if you do see it, that's our differential. Thank you, Shaima, and this is what they look like. So it's very interesting. I'm just curious how other people deal with it, and who knows what we'll see with it in the future.
glad that you showed that case, because I always was wondering by myself how other people do it.
Yeah, I think I was sort of like, this is overblown. It's kind of getting silly. If it's in 40% of the population, is it really clinically significant? There was like a recent paper out. I forgot, I should have attached it here, talking about how it can increase the risk of stroke, and it made a compelling point. So ever since then, I sort of started putting it in, but I don't know. I go back and forth. So I am curious to hear what other people are doing. Sorry. Okay. So now we're talking about the septum. So this is just a nice case, especially for board studying purposes. So if we're looking at the septum, so here we see that there's this area on CT. And if we look at it, I'm not giving you Hounsfield units, but it certainly looks just like the mediastinal fat. So this is an area of fat in the interatrial septum. So this is lipomatous hypertrophy of the interatrial septum. It's really nice, especially in this image, right? You can see that dumbbell shape where it spares the fossa ovalis, right? That classic shape. And this should really follow fat on all of our MR sequences. You can see here, it certainly looks like fat here as well. So why do we care, right? We don't, lipomatous hypertrophy in the interatrial septum is a benign finding, but the reason why we care, and the reason why we care on boards, is because this is brown fat, right? So brown fat is going to be hot on PET CT, as you can see here. So we just don't want to mistake this for a cardiac met, especially in a patient who's getting a PET CT. Presumably they have cancer. So that's one important thing to note. A little bit more about the interatrial septum, right? So now we have a mass on the interatrial septum. This is our next case. So this is a well-circumscribed mass on the interatrial septum. It's a bit lobulated, right? But it's sort of uniform looking. Can't really tell if it's enhancing here. It's sort of hard to tell, but the location and the look of it we're pretty certain that this is a myxoma, and that's what this ended up being. This was a cardiac myxoma. So these are the most common benign cardiac tumors. They're usually in the left atrium. They are attached to the fossa ovalis of the interatrial septum. They don't have to be, but they most often are. Here's another image of one. Here's another one, right? Like well circumscribed, really nice looking, low density. There isn't always this attachment to the interatrial septum, but when there is, it can be very helpful. And there shouldn't be any invasion. And a nice thing that you can see sometimes is you can actually see these prolapsing through the mitral valve, which is really interesting. So when you see that, that can also help increase your certainty that you're dealing with a myxoma. There's a second type of myxoma, and that's our villus type of myxoma, right? So again, these can prolapse through the valve. This is a less common type, and it sort of has these like frond-like appearance. So you can see that here. So don't be concerned if it looks more friable and frond-like, then it's probably just a second type of myxoma. On MRI, I think the T2 is really helpful, right? So these have a very high T2 signal. There can be some low signal if there's calcium in there, and then there should certainly be some delayed enhancement on our contrast enhanced images. But the T2 hyperintensity is very helpful. And then here again is just showing you another myxoma, right? So there's this frond-like mass. I think it looks a little bit scary, but then you look at it and you're like, well, it's in the left atrium. It's attached to the fossa ovalis of the interatrial septum, and it's prolapsing through the valve. So all of those things favor myxoma. It has that typical frond-like appearance. And then you can see here on first pass perfusion that it actually does show some enhancement. So this is compatible with a myxoma. These are our two types, right? So this is like our well-circumscribed lobulated type. This is what it ended up looking like on path. And then here's our more friable subtype. It really just looks like the CT image, which is kind of nice on pathology. And then here's that other one that I just showed you, right? So, I mean, it literally just looks the exact same. It's such a nice rad path correlation. So here we go. It's that pedunculated, but originating off of the fossa ovalis region. Okay, so case 3, I'll let this play for a second. Again, we're doing holes in the heart, right? So it's going to be another, or well, I guess we're just doing in the atrial septum. Okay, so again, we see, right, there's a hole over here. So there's a hole between the left atrium and the right atrium, but we're not at the same level that we were at before, right? We're like a little bit too high up. If you look here, you could see your right atrial appendage here. This is your SVC, and this is the left atrium. So we're too high. We're at the level of the SVC. So this is our sinus venosus ASD. So here's just to orient you with some labels, right? SVC, right atrium, left atrium. Here's our ASD. And here's another one, right? So you can see here. So we're at the level of either the SVC. You can also see it at the level of the IVC, although usually it's at the level of the SVC. And this is our sinus venosus defect. This is, again, seen in much fewer patients than our regular secundum. And again, these can actually be associated with partial anomalous pulmonary venous return when they are on the right. So that's an interesting finding. This patient actually did have both, right? So here's our SVC, and then you can see that there's a pulmonary vein draining into the SVC. So right-sided PAPVR, partial anomalous pulmonary venous return, and then they had their associated sinus venosus ASD. Case 4. So here's another one, just to, I think I have some more. Yeah, here we go. So here's the right atrium, here's our left atrium, and then you can see there's this dilated vessel that's coursing posterior to the left atrium, and we know what courses posteriorly to the left atrium and usually dumps into the right atrium is our coronary sinus. But in this case, the coronary sinus is actually connecting to the left atrium. So this is our unroofed coronary sinus, right? So this, here's another image, which I think looks really nice. So here's our right atrium, here's our left atrium, and then the coronary sinus is coursing around, and instead of going into the right atrium like it should, it has a nice connection with the left atrium. So that's, that creates a shunt. So this is very rare. This is the rarest type of ASD. And so now we have a communication, right, between the left side and the right side. Oftentimes, this is associated with a persistent left SVC and can also be seen in different types of congenital heart disease. Here's a companion case. I like this one. So this was on a cardiac CT initially. So this was the top slice of a cardiac CT. This is all that we had. And I was just scrolling through on the axial, and I noticed that there's some like beaking here, which looked sort of weird. And I looked at it with the resident, and we made the finding, and it's just like, it's pretty obvious when you see it on a chest CT, but just so you can see it on an axial, we didn't have a chest CT, unfortunately. The patient did go on to get a chest CT. So now you can see what it looks like on CT. So all that we're seeing sort of is like this right here. So this is our PFO, right? So our patent foramen ovale, or sorry, our PDA, patent ductus arteriosus, right? So we have, you can see the connection here between the aorta and the pulmonary artery. So I guess going back a little bit to coronary sinuses and left SVCs, I wanted to just go over some cases that also had x-rays. Here's a case. This is a portable chest x-ray. You have a patient where a central line was placed on the floor and it's not crossing into the brachiocephalic vein, into the SVC as we would usually see it. So the question is, where is this, right? And everyone always gets excited and says it's in the aorta. But, you know, this is the case where you call the floor and you say, I think it's in the aorta. And they say, no, it's not. It's venous blood and it's not in the aorta. So they go ahead and get a CT. And we thought, you know, maybe this could be a duplicated SVC, something like that. So the patient got their CT. And this was the finding, actually. So it's this small little vessel that we see often adjacent to the aortic arch. It's never, ever, ever normal to see a vessel adjacent to the aortic arch, right? If you see a vessel adjacent to the aortic arch, it's either this, right, which we'll talk about in a second, partial anomalous pulmonary venous return, or I guess a duplicated SVC, right, a left-sided SVC. So those are our three main things that we think about. So this is a left superior intercostal vein. Here you can see that there's a catheter within it. So it's kind of a small vessel. You don't really want to have a catheter in there. The reason why we care about this is because here you can just see on the illustration, this is what we're talking about. So you could see how a catheter could slip into there. So this is, it makes that characteristic appearance on x-ray of the aortic nipple, right? That's given it this ridiculous name, which is why everyone likes to ask about it. So this is our left superior intercostal vein. If you're shown this x-ray and they say, what do you do with this nodule? The answer is nothing, right? It's a normal part of our anatomy. So here's a companion x-ray, right? This patient has a port in their SVC, right into the right atrium. But then now they also have this Hickman on the left. So it's a Hickman, presumably. It was placed under fluoroscopy. So I can't imagine that this is an arterial stick. So the question is, where is this, right? So this is a patient who has, again, something adjacent to the aortic arch, to the left of the aortic arch, which there should never be anything there. And when we look, there's no, branches going towards it. This is just a duplicated left SVC. The patient also has their right SVC that had their port in it. And you can see it's pretty symmetric. So a duplicated left SVC, again, not a shunt, right? So these 98% of the time or so, right, are going to dump right into the coronary sinus, into the right atrium. So it's not a problem. It's just important to know so you don't freak out when you see that there's a line there that shouldn't be there. This is what it looks like on MRI. So here we have a black blood sequence. You can see here's our vessel, and this is a contrast enhanced sequence. And you can see there's contrast going into the left SVC here. In general, you can have an absent right SVC with the left SVC, or you can have duplicated both of them. I actually had a case this week of a unilateral left SVC, which was kind of interesting also, just incidental. Okay, so here's another one, right? Okay, so in a stack of like 100 x-rays in a day, I probably would miss this one. This is a left central venous catheter. It's coming down, and I probably would have said it's in the SVC. But if you look at it closely and you take a second, you realize that the trachea is to the right of this line. And our SVC should be to the right of the trachea rather than where this line is. So this is too medial for us. So the team was informed and they ended up getting a CT. And you can see that this is our dreaded carotid stick, and this one went straight into the aorta. Obviously not great for the patient. And here it is just sort of floating around in the aorta. IR had to go in and pull it out and put in a covered stent in the carotid. Was that it? Oh, I guess that's it. I really thought that there were a few more, but maybe this is not the right version. Does anyone have any questions, any cases you wanted to discuss, or any cases that you want to share?
Those were awesome.
Thanks, Jonathan. How are you?
I'm well. How are you? I'm getting over a cold.
So for the last case 6, they did put the stent because they perforated. So they were aiming for the venous, got the arterial, and then the stent is because something very bad happened.
So when they, I have to remember this case is from like a few years ago, but they took the patient to the OR because they didn't want to, I think actually IR went and did it in the OR. They were nervous that when they pulled the catheter out, there would just be, they wouldn't be able to control the bleeding, essentially was the concern. So I believe they pulled the catheter out and put the covered stent in, and the patient actually did okay. There have been other cases I've had where they pulled the catheter out in the OR with IR and surgery on standby, and the patient ended up not needing a stent, like they didn't actually put one in. So I assume it has to do with the catheter, the patient, how long it's been in there. Because certainly it would be a shame to open the patient up just to, remove a catheter that was malpositioned. But I do think at least where this case is from my prior institution, they usually prefer to do these in the OR just in case the patient needs to be opened up. So I don't remember if there was actually a hole and they couldn't control bleeding and then they put the stent in, or if they just did it, sort of when they removed it just out of caution, just because of the hole right in the carotid. I don't remember what the case was, but they definitely just did put the stent in, and the patient did okay.
Thank you.
Sure. Good question.
Wonderful cases. Thank you.
Thanks, Shaima. Yeah, I guess that's all that I have for today. It was a quick one. I think I went too fast, but it's good. I'll give everyone back some time for their day. And thank you again, Shaima, for your thoughts. That was very helpful. And I'm curious to see what's going to happen with those septal pouches.
Yes, me too.
Yeah.
Thank you very much.
Yeah, sure. I'm going to stop recording.
Bye-bye.